Welcome to episode 212, a paradigm shift in treatment of chronic pain, expanding beyond opioids into other options, featuring Dr. Mel Pohl. Make sure to subscribe to be alerted about future episodes by Clearly Clinical. Learn, grow, shine. Hello to our listeners. My name is Beth Irias, and I am so happy to be joined today by Dr. Mel Pohl. Dr. Pohl has been part of the addiction management treatment world for such a long time. He's a fellow for the American Society of Addiction Medicine and also a senior medical consultant for the pain recovery program at the Point Malibu. Thank you so much for joining us, Dr. Pohl. It's lovely to have you.
It's great to be here, Beth. Thanks. It's good to see you.
Good to see you too. Dr. Pohl and I go way back to a time when I don't even remember when we met. But
right.
It's lovely to have Dr. Pohl. For our listeners who aren't familiar with you and with your work, please take a moment to tell us about yourself.
Okay, so Dr. Mel is my rebrand. So if you're going to call me Dr. Mel or just Mel. So I started family medicine, trained and did a residency in family medicine, got a job in Las Vegas, and inadvertently was hired to be the assistant medical director at an addiction treatment program. So it wasn't what I was looking for, but I ended up learning a lot about addiction. 3 years later, I got sober. So I was running the program, for the first 3 years, actively using substances. So I have a real insight into denial and, an ability to connect with people who have substance use on a personal level. But also for the past almost 40 years, I've been running a variety of different addiction programs, mostly in Las Vegas. That's where I moved in 1979. And 20 years ago, when the opioid epidemic really was hitting hard, we would see a lot of people on opioids who were I would detox them, get them off their opioids. This was pre-Suboxone. It was just methadone or abstinence. And in this abstinent state, people would come to me and say, well, what are you going to do about my pain? I take pain medicine for pain. I'm not getting high. I'm not, shooting up. I'm not going to the street. I'm taking what I'm prescribed. And I got real interested in the fact that we were, in essence, mistreating patients who came with a pain condition and ended up becoming dependent on opioids, and their pain got worse. So that's kind of my road to learning about pain. And then a couple of years ago, I was recruited to come and work at the Point Malibu, which is a lovely facility on the beach in Malibu. Great care, and put together a team of professionals better than any I've ever worked with. I mean, it's a very committed group of clinicians, and I work with a pain psychologist, Les Aria, and just it's just a great work environment, and we're able to do really, I think, groundbreaking work for people with chronic pain.
Fantastic. Thank you so much for joining us. So in this conversation today, before you and I started recording, you had said, really there's a misunderstanding about chronic pain and how it relates to addiction. Why don't we start there today? Can you talk about really what pain even is, differentiating chronic from acute, and we'll start there.
Yeah, let's start there. So the major there were a series of misunderstandings in how the medical profession and how subsequently the clinical professions and patients and families have come to understand pain. And the misunderstanding is that acute pain and chronic pain are related in any way, because they're not. The only thing that those two conditions have in common is the word pain. Acute pain is related to tissue damage. It's short-term, it's purposeful, functional. If I sprain my ankle, the signals coming from my ankle are meaningful, and they say to my brain, don't walk on that ankle because it's damaged. The ankle heals over time. That's also differentiates acute from chronic pain, and the condition resolves. So acute pain is what pain is for, if you will. Chronic pain, long-term, unending, unremitting, But the real key, Beth, the real thing for listeners to understand is that chronic pain as a result of persistent signaling in the nervous system results in a reverberating signal up in the brain that has nothing to do with what started the signal going, which is in the tissue. So one of my catchphrases is the tissue is not the issue. The issue is the nervous system, and we refer to that as central sensitization or learned neural pathways. These are truly different signaling phenomena that occur in the being, the human, but it really is all about the brain. And the important thing to understand is the part of the brain that's involved is what's known as the midbrain. And the midbrain is a very complex multi-billion cell set of organisms inside or not organisms, but organelles inside our brain substance that's involved in not thinking and reason and judgment, but rather instinctive, survival-based phenomena related to emotions and related to drive for pleasurable things. And of course, that's where the drugs work. So inadvertently, people who have a painful condition, unrelated to the structure now, but that's kind of created this cycle after 6 months of, again, reverberating circuits in the brain that say something's wrong in my back when actually something's wrong in my brain. We prescribe medication for that condition as if it's an acute problem without any foresight into what's going to happen. And that's what we did. And we did that with the help of pharmaceutical companies and pressure from patients and families alike because, physicians want to help. I think this was not a nefarious undertaking at the beginning. I think somebody comes into a doctor's office, they say, I have this pain condition and I have a prescription pad in 10 minutes. So what am I going to do? I'm going to write a prescription for medication, which I believe is going to help you. And I believe it's going to help you because I was told it's going to help you by influential physicians that were employed by the pharmaceutical companies. So the message was, this is the right thing for chronic pain. You can give it for the rest of their life. They won't become addicted. You can go as high as you want. And of course, the result of that was increase in overdose deaths, an increase in dependence and addiction, and all sorts of complications as a result of this misguided effort to take away this painful condition.
Thank you. I think that paints a really helpful picture. If I'm understanding correctly, essentially chronic pain is the echo. It's not the original sound, but it's the echo of what happened before that's keeping the brain on high alert to produce the sensation of pain. Is that right?
Yeah, that's very well conceptualized. It's not how I'd refer to it, but it is in essence. I mean, take as an example, because chronic pain, we're talking about conditions like chronic headaches, interstitial cystitis, irritable bowel syndrome, chronic regional pain syndrome. And the classic example that's worth talking about is an amputation. So if we have a limb that's been cut off because of any number of conditions, we still feel the limb as if it's there. We have a pain experience, and the pain is, of course, not in the limb because the limb's gone. So where does the pain live? The pain lives in the brain. And if you look at the brain, there's actually a map of areas of the body that are reflected in the brain. And that area of the brain says something's wrong. And even though it doesn't correspond to the actual part of the body because it's gone, it feels like, if I had my hand cut off, God forbid, it feels like my hand is inflamed and on fire. So phantom limb is a good example of this phenomena of chronic reverberating, if you will, or echoing signals that live in the brain. And one thing I don't think I said yet is that the part of the brain, that middle part of the brain, is also responsible for emotional responsiveness. So fear, anxiety, depression, anger are all drivers of the pain experience. And they're much more important than the structural nature. And, the best example of the way we went off track is that we operate on people with pain in their spine, typically. People come in with back pain, they go to the doctor. MRI scans always show something because after 20, we all have degenerative disc disease. And after 40, we have spondylolisthesis and all sorts of serious medical conditions that do not necessarily correlate with painful conditions. There's a bunch of asymptomatic people. If you look at their spine, they start to cry because it looks as if something's really wrong. And even though something's wrong, we talk about the gray hair of the spinal column. I mean, it's just an aging phenomenon that the discs are not sharp and clear. There's this sort of irritated areas, but that doesn't necessarily correlate with pain. If, however, as a surgeon, I see that on the MRI, I say to the patient, you have this degenerative disc. It corresponds with your pain. I'm going to take away the degeneration. I'm going to put in an artificial disc, or worse still, I'm going to put titanium rods in your spine and fuse it so it can't bend and press on the areas that are problematic. That's such a misguided effort. Rarely helps. And we end up with people who, in a futile attempt to solve a physical problem, they ignore the fact that when they're anxious and when they're frightened and when they're angry and when they're depressed, pain is off the charts. And the essence of the work that I do with the team that I've created, and the essence of the message is you have to deal with the thoughts and feelings related to the pain, or you're never going to get better from chronic pain.
I have so many questions. So when thinking about the relationship between feelings and pain, goodness knows, I think all of us have experienced that to one degree or another. It's a relationship that I think we know is there, that if we're stressed, for example, we may get a headache or we're going to have a stomach ache or whatever. So this relationship, many of us are familiar with. When we're looking at it through a more chronic angle, one of the questions that comes up for me, can you speak a bit about chronic pain and inflammation?
Sure. But I want to go back and say that when I'm anxious, my head hurts. And I had a patient who actually, I do this kind of educational process because it is part of treatment, is educating people about the fact that the pain is not primarily structural. It's primarily circuits in the limbic system. And one of my patients got furious with me because she said, well, you're telling me my pain is in my head. And I said, well, you have chronic headaches, so where else would your pain be? But the implication was, if it's in my head, then it's not real and I'm full of crap. I'm making it up. And that's the way the medical system responds to people who come in with chronic pain. I've operated on your back. I did everything that I was supposed to do. You should be better. You're not better. It's your fault. Go see a psychiatrist. Pejorative. And, yes, see a psychiatrist, but not because you're crazy, because the way in which your emotions interact with your pain system is problematic, and that needs to be dealt with. So let's shift and talk about your question, which is safety and inflammation. So we were talking earlier about polyvagal theory. So the essence of polyvagal theory is that there's a safety system inside the human being, inside all organisms, really, even primitive one-cell organisms, but it's very sophisticated in the human being. And in humans, the vagus nerve, which is the 11th cranial nerve, is the one that's really on alert to improve our sense of safety. If we are threatened, so let's say we're attacked by a lion, there's several things we can do. One is we can curl up in a ball or like a tortoise, pull our head into the shell and make like we're dead and hope that the danger passes. That's the freeze response, which is common with trauma. More commonly and more, probably 90% of the people that I see are activated in a sympathetic nervous system. That's the fight or flight nervous system. So that's, something's wrong. I need to either run away or attack. And that's cardiovascular activation, heart pounding and pupils dilated, on alert, not resting, not comfortable. The threat response, either one of those threat responses, is associated with inflammation. When we are under threat, inflammation happens, and it happens biochemically. I mean, there's things called cytokines. If people are familiar with, they reference this with long COVID, was cytokine storm. So that's inflammatory neurotransmitters that are just around in our bodies that if we are under threat, they become activated. It makes sense that they're activated because we're threatened. So what do we do if we're threatened? We try and fight off the threat. And inflammation is actually the body's attempt to fight. If you have an infection, we get inflammation. White blood cells come and all these other things that scavenge and take away all the poison and kill off the virus. That's the purpose of inflammation. We've misinterpreted that too because we think, inflammation's bad. We should take Motrin. We should take anti-inflammatories to take away the inflammation. And what I've learned in the last really several years is that that's not the best course most of the time. Injecting cortisone, anti-inflammatory medication into a joint gives you temporary relief. However, if there's a reason for the inflammation, healing, and this is complex, but there's a phenomenon called salutogenesis, which is actually healing is enabled not only by taking away inflammation, but by providing adequate nutrients, restful conditions, the ability for the cell to regenerate and heal itself depends upon safety. If we are under threat, the cells can't do their jobs. So the problems are eliminating the source of the inflammation that comes from perhaps the outside or injury or damage or infection, but also fostering a sense of safety. And that's what applies to really managing chronic pain. And, just to reinforce that all things we're talking about are biophysiologic. They're not, made up figments of the imagination or, as you said, psychosomatic. There's a sort of duality. It's either in the mind or the body. Well, I got news for you. The mind is part of the body, right? The mind comes from the brain and the brain is integral in the body. And by separating those two, we have doctors that operate on the body, and then they send people off to the mind doctors when they failed in what they think is the right treatment for the structure, when actually going after the structure is ill-advised.
What I'm understanding is big feelings related to threat keep our nervous system activated, contributes to inflammation, which is then making pain worse. And I would assume impacting our functional capability and just what we're going to say about life. Life is not fun when my head is pounding like this, or I can't do yoga anymore because my joints are aching. Therein lies the problem of separating mind and body.
Yes, and it turns out you mentioned yoga. Yoga is the integration of the mind with the body, and it's one of the mainstays of actually chronic pain interventions is do yoga. So, the typical response is, I can't stand on my head. I can't stretch like the instructor. I get self-conscious, and it hurts. So we help people notice the experience of discomfort without the backstory, without the judgment. So the pain, this monolithic, evil, dark force becomes an interesting sensation. I have an interesting sensation when I move my shoulder this far and then I go further, I feel it. Okay. So then pull back right at the edge and then go again and keep going and keep going. And eventually, as you can imagine, you can move a little further because you will eventually stretch the tissues and you'll eventually lubricate the joints and you'll eventually enable oxygen to get to those tissues and the scavenger cells take away the negative stuff that's in the joint, and you'll end up with increased range of motion and less discomfort. Doesn't mean you're pain-free. The goal of pain-free is a problem because there's only one thing that causes us to be out of pain, and that's general anesthesia. If you are thoroughly asleep, you will not feel pain. But we don't function that way. And you reference function. The main purpose of pain treatment for chronic pain, is to enable people to function better. So rather than what's the matter, what matters to you? What's important in your life? And so often, as you said, people lose track of what's important to them. They're not interacting with their family. They're not finding pleasure or engagement in things that used to engage them. They feel bad all the time, dysphoric. And chronic pain treatment really goes after the dysphoria, but also it reintroduces positive affective states or joy.
Goodness knows that there are innumerable contributors for chronic pain. Could be an old injury. You had referenced a shoulder. Um, I was fortunate enough to have a number of shoulder dislocations in my childhood.
Yeah,
That
yeah.
every once in a while I make it mad and it becomes more chronic. Can you define really quickly acute to chronic? Like, where is that line? Given that we live in a world that really wants to define things, if we're looking at any diagnostic manual, it's going to say, here's the line. What is the line for chronic?
The official line from the World Health Organization is 3 months. So pain that lasts more than 3 months has shifted from acute to chronic. Acute pain should resolve within 3 months, and usually it's within a month. If it's beyond 3, and then I say 3 to 6 months, there's a new process happening. And there's actually a biochemical process. It's so interesting, Beth. It's called chronification of pain, and it was described by this guy, Ebkarian at Northwestern University. And he basically showed that over the course of time, there was this inflammatory process that we've been talking about, and it's essentially negative neuroplasticity. People are familiar with the brain being plastic, right? It's capable of changing in response to stimulation. So in response to chronic exposure to a pain signal, the brain says, oh, this must be significant. And it becomes more adept at handling. There's a phenomenon actually called wind-up in the spinal column, so that it takes less to cause a response over the course of time because of this tightening of the spring response, if you will. And it's misguided in the sense that this isn't about the tissue. This is about this sort of self-motivated, if you will, or echoing system inside the middle part of the brain that has misinterpreted. And this is really key. Alan Gordon and his group at USC have spoken about this. He created something called pain reprocessing therapy, which hopefully we'll get to talk about. But Alan's main point when he teaches is the brain has misinterpreted. It thinks there's something terrible going on. It thinks, oh, I injured my shoulder, and now, 10 years later, that's what's causing my problems. And the conviction that there's something wrong is misinterpreting. It's the brain saying, uh-oh, something's wrong, when actually everything's fine. Yeah, there's a strong sensation in my shoulder. It's no big deal. I can lift my arm all the way to the sky, even though it really doesn't feel great. I'd rather not do that. And my suggestion to people like that is do it anyway. Hurt versus harm. It's not going to harm you to stretch to the max, and you will have benefits of doing that.
Then one of our goals clinically is to alter someone's relationship with their pain.
Yeah, well said. Absolutely. The conviction, the beliefs that I feel this means that has to be uncoupled. And that's really part of the work. There's I can mention pain reprocessing therapy now because that is the uncoupling process. And there's an article in the Journal of the American Medical Association Psychiatry, very prestigious peer-reviewed journal last year, and it was about the Boulder back pain study. So essentially, the Boulder back pain study took 150 people with back pain. The average length of time they had pain was 11 years. So it wasn't just, it was really chronic pain. And these were people who were somewhat disabled, but they were able to walk into the clinic. They divided them into 3 groups. One group was placebo. They didn't get any treatment. They just were put on a waiting list for treatment. There was usual and customary, which was cognitive behavioral therapy and physical therapy once a week. And then they did this other group called pain reprocessing therapy. So let's drill into that. Pain reprocessing therapy has 5 parts. The first is the education that this is not structural. So understanding the neurophysiology of how pain develops and how the brain misinterprets. The second and very important step is it's called self-examination, or we call it Sherlock Holmes. So it's basically looking at evidence That's like one day my right side hurts and one day my left side hurts. If you have degenerative disc disease of the spine, why does it hurt sometimes and not others? Well, if I walk too much, well, how far do you walk? And when you walk with somebody and you have a conversation versus when you walk alone, and it turns out I can walk 3 miles when I'm having a conversation. I can only walk 1 mile when I'm walking alone. So we begin to shine a light on the truth, which is this is not, at least it's not totally about structure. The third is actually a guided visualization called somatic tracking, where under the influence of a therapist, we actually walk through the different physical experiences and notice how they change, how they get bigger, how they get smaller, and without judgment. So it's really sort of in a mindful way, just pulling back from uh-oh to huh. And with that shift, the experience is different. One of the key things that Alan says is that we need to be outcome agnostic. So we can't say for this to work, I'll be out of pain. We can't say, I got to get this pain gone, because if we do that, we're already tense and anxious and, sort of in our overachieving methodology causing more problems. So it's really about laid back interest, curious. That's my favorite word these days. And with curiosity, I notice certain trends in the pain. And then I begin to say, well, if what I believe is true, then this doesn't make any sense. So how can I reconcile the two? I can reconcile the two by saying it's not the structure, it's the brain. The fourth issue is to really deal with the things we touched on briefly, which is the other emotional and traumatic experiences like depression and anxiety and fear, and big one is anger. People invariably have worse pain experiences when they're angry. And then the fifth one is the positive affective state, introducing joy into the picture. Joseph Campbell said, look inside and find the joy, and the joy will burn away the pain. So this 5-part treatment was done twice a week for these boulder back pain patients. And at the end of 6 weeks, 67% had gone from an average of 5 out of 5 pain to 0 to 1 out of 5 pain. And at a year, 55% had a persistent of that improvement. So more than half the people who entered this treatment had a decrease in their pain a year later. And then the coolest part about this is that the actual brain was studied. So they did an MRI scan, functional MRI scan. So they scanned the brain out of pain, and then they blew up a pillow to cause back pain, and they scanned the brain. And what happened at entry changed so that there was less activation of those areas a year later. So it was significant, it was structural in the brain, and it was lasting improvement. And it's pretty cool. And then they did a follow-up study. It's called the reattribution study, and the attribution study, and they basically looked at who got better, and it was people who really shifted their awareness and their belief this is structural. When they believed it wasn't structural, when they believed it was internal in the brain, they got better.
Interesting. Thank you for sharing all of that. And for our listeners,
It
is a lot. For our listeners who want to learn more about some of the concepts that Dr. Mel's talking about today, we have some really interesting episodes featuring Dr. Steve Grinstead, where he's talking about what's called the Gorski method. And that understanding of pain management is more appreciation of the relationship between our thoughts and how that influences our experience of pain. So whether we interpret pain as throbbing, for example, which is a description of the pain, or debilitating, which is a meaning associated with the pain. So for our listeners, if you want to learn more, particularly about kind of this idea that Dr. Mel is discussing, take a look at those. Those are the chronic pain episodes featuring Dr. Steve Grinstead. But back to what you were saying, Dr. Mel, it sounds like really it's trying to soften this sharp signal that our brain is giving to register that there's pain. And by coming at this from a multi-pronged approach, people are feeling better without the enormous drawback, which I want to talk about, of opiates. So let's go there, because certainly as you and I are recording this, we're early in 2024. so much more information has come to light in the last 10 years, so many problems with the way that the Western world had approached particularly chronic pain, but even acute pain relating to the use of any number of different, pain management medications. Can you give us a bit of a primer in looking at the problems with just relying on quote unquote pain meds to address pain?
So, briefly, acute pain, one of the key studies that came out, and this is in 2016 when the CDC came out with their first set of guidelines, and they basically said stay under 50 morphine equivalent milligrams per day because 50 or higher increases the risk of overdose deaths. The pushback, you can imagine where that came from, was the pharmaceutical industry was dramatic. And as a result, 3 years later, the CDC revised their guidelines. They didn't say anything different, but they softened the language. And they pretty much said, here's one way to do it. You might want to think seriously about doing this. However, you may not be able to achieve these results and get people off opioids. So, but back to acute pain, what they found, the one study by Shah, I believe, and this was a number of years ago, showed that of the people that took acute pain meds, after 10 days, if they took them for 10 days, there was a 25% likelihood that they were going to be on them in a year. If they took them for 30 days, there was a 30% likelihood they were going to be on them at 3 years. So it really said if you give a lot of acute meds, it's going to result in use chronically, which was at least acknowledged at that time that it wasn't a good idea. So the new revised guidelines said don't give a whole lot of pills. Don't give a prescription for 60 Norco after a minor surgical procedure or a sprained ankle. Give 5. And they had studies of women after hysterectomies and, that took opioids for maybe a day or two. So that's point number one is opioids for long periods of time, even for acute pain, is not a good idea. If you have a severe reaction to a surgery, get a supply of opioids, use opioids, but time limited, get off them as soon as you can. That's point number one. So what about chronic use of opioids? The message that I got when I was in family practice was use as much as you want. They can't get addicted if it's real pain. They actually use that terminology. And yeah, it's easy to come off of, no big deal. And you can go as high as you want. If the dose stops working, go higher. There's no ceiling effect. Well, what's the truth? The first truth is all of that is lies. You can become addicted. You can become physically dependent. And most people who take opioids for longer than 3 to 6 months will notice that they've developed a dependence. What that means is that if they don't take the pill, they don't feel quite so good. They can do it. They might not identify it. And more importantly, for pain, in between doses, their pain goes up. So when we're dependent, we become tolerant. So that means the dose doesn't work. I got to use more. If I use less, I'm in more pain. And then if I try and stop or I go 6 hours instead of 4 hours, the pain increases in that last 2 hours, driving me to use more medication. And then the real kicker here, Beth, is that there's a phenomenon called opiate-induced hyperalgesia. And that's fancy words that say opioids cause more pain. They induce hyperalgesia, more pain. And the way they do that is they actually inflame certain cells of the brain called glial cells, support cells, to cause inflammation in the brain. So go back to opioids for pain on a long-term basis. They are pro-inflammatory. They cause inflammation. And we prove that by seeing a high percentage of the patients that I've treated over the course of my career. We take them off their opioids and their pain doesn't go away, but it gets much better. So more pain on opioids, a big warning for folks should they embark on an opioid course or if they're on opioids long term. If you've got a client who's taking opioids long term, they need this information. Now, this is a tough sell. It's not an easy, adaptable, then I'll just stop my opioids. And by the way, if they're dependent on opioids, they need medical assistance to get off those opioids. But the long and the short of it is, if I'm on opioids chronically, my pain's probably worse. And there's no good evidence that taking opioids long-term benefit people with chronic pain. And typically, there's a number of studies that say the function goes down, ability to go back to work goes down, ability to concentrate goes down, ability to sleep goes down because of the effect of the opioid. So it's a bad premise to be on opioids long term.
Absolutely. There's so much in what you just said, and knowing that we are talking about opioids in relation to chronic pain and wanting to keep that focus on chronic pain, I do have a couple of questions about opioids. 25 years ago, it was the magic pill. If you have an injury and you end up in the ER, take this, insert opioid here, and it'll really help you manage that pain. From a practical perspective, how much do opioids help with acute pain?
They help substantially. I mean, what they do is they numb the brain. So the opioid system, we're built in, and the opioid system is responsible for pain. So endorphins work in the opioid system. They decrease pain when we exercise, for example. Opioid medications work to decrease pain. If you never took an opioid, it would be your own endogenous opioids that would show up that would take the pain away when the need for pain was gone. So the reason acute pain heals without any intervention is you don't need it. The purpose of pain is don't walk on this ankle. As the tissue heals, the signal subsides and the brain says, okay, we're cool. So there are endorphins and natural opioid chemicals that are being secreted that say everything is okay. It's the basis of placebo efficacy. Placebos work because I tell you they're going to work. How does that happen? You believe they're going to work, and your brain is able to make its own opioids to create a benefit. Now, you might want to wonder what happens to that system if I give you an opioid from the outside. It's modified. And if I give it to you once, no harm, no foul. If I give it to you 10 times, probably okay. If I give it to you every day for a month, all of a sudden, your own opioids aren't doing what they're supposed to do because you're getting it from the outside. I mean, that's the real issue with any addiction, right? That we're changing the homeostasis of the system by putting something in, whether it's alcohol to depress or stimulant to excite or opioids to take pain away. And the result is going to be a backfire because the brain doesn't want to be messed with. Should we ever use these things? We should judiciously use in certain circumstances based on benefit versus harm. And that's really the key that we missed when we did this opioid prescribing was we thought pain relief was the benefit, but we didn't see, we didn't use, the Buddhists call it foresight wisdom, like what's going to be like a month from now and 3 months from now and a year from now.
So to completely oversimplify this, if something works in the short term, if we're looking at opioids, have an injury, let's say, at some point in time, prescribers went, well, if it works in the short term, then it should be fine in the long term. And that changes the way that the brain is actually registering endogenous pain. And in doing so, the system becomes haywire, helping to drive addiction to opioids.
Yes. At first dependence, and then for some people, addiction.
And when you say dependence, are you talking dependence behaviorally, or are you saying dependence as in physiologically, this is how I'm going to stabilize these receptors in my brain?
Yes.
Okay. All the things.
Well, because, psychological dependence happens in the midbrain. So the reward system is inextricably linked to the relief system. And the definition of addiction is pathological pursuit of reward or relief. And for people who are dependent on opioids, they can't tell the difference. They just want to be out of pain. And being out of pain feels good. So, it's not like they're getting high. I can tell you that. They're not having a blast. But some of my patients who are dependent on opioids will say, I feel better when I'm on an opioid. And it's not just pain relief. They give me a little bit of an energy boost. They give me a sense of well-being. And that is the reward system, again, inextricably linked with the relief system.
It's remarkable when you think about it. Having worked in the addiction space for quite a while, spent a lot of time looking into, how did we get here? How did the United States get here with the opioid epidemic? Why did it happen here? And there, of course, there's a pharmaceutical component. But one of the interesting things that I want to throw out there for listeners that really struck me was this idea that Americans also have a different expectation about pain. And so when we asked folks from different countries, basically at what point does this pain become intolerable to you? Americans said faster. We said it's intolerable sooner than other cultures, which, if we're deconstructing all of these complicated factors that contributed to where we are now with so many people who are actively addicted to various opioids without even mention of things like fentanyl. This is such a complex phenomenon. And I appreciate you, Dr. Mel, coming on and simplifying it and breaking it down, because it certainly helps me understand how did we get here, and then how do we as clinicians help to get a little bit of a wedge in there to make space for the body's natural reward system to start working again when it's essentially been hijacked by external opioids.
Yeah, that's well said. I mean, there's so many areas where we got it wrong, in essence, and the belief of I actually think there are four parts of the problem. The first one is that doctors believed the second one, which is the pharmaceutical industry. They misguided physicians. They misled us. We weren't as critical as we could have been. But, the famous study that was quoted by Purdue Pharma when their reps went out to see doctors was that only of 40,000 patients that were surveyed, only 0.4% developed addiction when they got opioids chronically. The truth of that study was they went into a hospital, they surveyed hospital records, and this many took one opioid, and then at the end of it, they looked for the word addiction in the discharge summary, and it was only there 4 times out of like 15,000. Well, bogus from the start to the finish, but that study was their basis of saying you can't get addicted if you take opioids. So misinformation from the pharmacy, belief, gullibility, if you will, but also desire to help. You come to my office with pain and you say, I want to be out of pain, doctor. What are you going to do for me? I don't have much, as I said earlier. I don't have much time. I don't have the ability to have this kind of conversation. I don't even have the knowledge to have this kind of conversation. And I got a script pad. And it's effective. It brings you back. It's easy. And I think it's going to work okay. If I had really shined a light, I might have opened the book and said, maybe that's not a great idea. But I didn't do that. So doctors participated. Pharmaceutical companies participated. Then we have the patient comes in wanting relief, just as you said. And, the U.S. has 5% of the world's population, and we consume 90% of the world's opioids. So it is a U.S. problem in many ways. The term chronic pain doesn't even exist in Europe as a diagnosis. It's not a diagnostic code. So, there's an element of I want to feel better now. It's the now generation. And, of course, we see it in social media and, all the kind of fixed things that people are attracted to in our culture. And then the fourth is the government. They allowed this to happen. They saw it. They knew it. The FDA had people on their committee that were employed by Purdue Pharma that misguided and really violated ethical standards, let alone probably legal standards. But they allowed this to happen. I mean, I remember I was on I guess it was a call or something. There's a guy named Andrew Kolodny, very outspoken about the opioid epidemic. And Andrew and I were co-leading this effort about a new drug called Zohydro, which was like the OxyContin of hydrocodone. It was a slow-release hydrocodone in the middle of the opioid epidemic. And they got a routine rejection from the committee that advised, and the FDA approved it. So how did that happen? So they got a rejection from all of the consultants that they worked with then said, this is a bad idea. We don't need this drug. We have enough. And if we have a high potency drug that's slow release, that's what OxyContin was. So let's not approve it. The FDA went ahead and approved it. And it's on the market today, Zohydro. So, and the setup is, if you have a slow release tablet, if you crush it up and then snort it, it becomes a very fast relief tablet. And that was what happened in the beginnings of the opioid epidemic with OxyContin.
Thank you. Thank you for so much information that I know I'm going to be thinking about and just processing. So you've addressed, just scratching the surface really, of what medicine and mental health care can do for somebody who finds themselves now deeply addicted to opioids. I'm curious, for the person who has that unbelievable car accident, they end up in the hospital, they're given opioids. I'm curious, what does the prevention model look like for you, for someone who has studied this so much? You have a family member that has this happen and they're like, okay, I have this major leg injury. They're giving me opioids. What does your treatment look like, knowing what you know, to try to prevent dependency on pain management medications?
So, a high level of acute pain, essentially, that's potentially going to go on for a while. It's going to be a clinical management challenge, because it's as little as possible for as short a period as possible, and then end the dosing of the opioids. And that's going to be very complex interaction between the prescriber and the patient. There's no formula that says don't take them, because if you're in excruciating pain, and again, pain is subjective. So, we have this ridiculous scale, 1 to 10 scale. It's totally subjective. Your 8 is my 10. I had a patient who's a 15 out of 10, and she was outside smoking cigarettes during a break, not calling an ambulance because her pain was so terrible. And it's not to say she was exaggerating. It was just her sensitization of her brain from the course of time was high. And that, by the way, has to do with genetics and trauma. I mean, there's a lot of things that govern a person's sensitivity to pain, whether it's very high or very low. But having said that, as little as possible, short a time as possible, and get your house in order, your mental house in order. So deal with threat physiology. Learn about, there's a vagal nerve stimulator that's called SSP, Safe and Sound Protocol, which is actually an auditory program that stimulates the vagus nerve. And I didn't really talk about the cool part of the vagus nerve, which is called the ventral. That's the one from the neck up. So it's how we create safety as humans from a phenomenon called co-regulation. And that's you and me, having a conversation, seeing each other, noticing your smile, noticing your tilt of your head, hearing the intonation of your voice. All those things create safety. And working with a therapist who is trained in those skills, in facilitating safety in the patient's nervous system, is critical during this time, if and when opioids are used. And then at some point, if they have been used chronically, there's going to be dependence, and there's going to need to be some sort of a detox or withdrawal. And it can be as simple as just titrating down over the course of a week, or it could be as complicated as going into a detox hospital and getting medication under supervision. So, stopping suddenly isn't a good idea. The other thing I'll mention is that a combination of benzodiazepines like Valium, Xanax, Ambien for sleep are contraindicated with opioids. So if you're taking opioids for a chronic pain or an acute pain condition, do your best to avoid these other habituating medicines, which can exacerbate the overdose risk and also exacerbate the complications of addiction.
Thank you. I appreciate you throwing that element in there. To translate what I heard in what you were saying, I think because it was, really powerful when you mentioned co-regulation. The therapist in me is like, yes,
Yeah.
this makes so much sense.
Cool.
Yeah. So what you're saying is basically, if we're trying to get away from opioid use, particularly in a chronic environment, you said you want to regulate the fear and threat response system, and that one of the ways to do that is through the use of polyvagal theory, but more specifically co-regulation. This idea that when and I'm laying on some interpretation here, but by our amygdalas firing, our brains start to hum, and that this brings down our nervous system, thereby, again, I'm interpreting here, but thereby reducing cytokines, reducing inflammation, therefore reducing pain. And so you're really linking together all of these different concepts, which I think is really helpful because it goes back to what you said earlier, which is, yes, it's in your head, but that's not because there's something wrong with the way you're thinking. This is the way that the brain is designed to relate to the body.
Yes. And yes, and it's just really expanding that model to deal with the question you pose, which is acute pain. If you are, if you're going to be on opioids, what can you do? And it's the same as what you can do if you have chronic pain. We actually have 5 points that we created, and they're called micro practices. The first one is breath work. So really there's 4, 7, 8 breathing, box breathing, and there's the series that anybody can Google if they're not familiar, but they regulate the nervous system or facilitate regulation. There's thought management, so it's certainly cognitive measures can be helpful there, but it's really that rumination and cognitive distortions that happen. My back is killing me, and I'm not going to be able to handle this, and I'm a loser, and all those other kinds of things. There's mindfulness, so we teach people to meditate and encourage them to do that before they get out of bed, but certainly before they look at their screen. And so that's the third. The fourth is it's play. So really, sort of getting into a lighthearted space where the irreverence that DBT teaches us is one of my favorite clinical techniques, which is, this really sucks. Now, what else are you going to do today? Where's the benefit? And the fifth is movement. So gentle movement, absolutely essential to get things lubricated, as we talked about earlier. So those 5 key points, we encourage our clients to get started on those really from the first day they get there. Of course, there's resistance to doing that, but we do get people up and moving. We enable them to have some time to really do some of that contemplative work and also the meditative work and breath work as well.
I want to restate those for our listeners. Those 5 were breath work, thought evaluation. I don't know exactly what your language was on that. Meditation.
Thought management.
Thank you. Thought management, meditation, movement, and play. What's interesting to me is how unbelievably simple this is. And this has always struck me as a parent. I thought it was really interesting when I had infants in the home that we pay attention to all of these cues and we look at all this balance of like, oh, they're yawning. That means we need to go down for nap time. And then we work really hard with babies and children to make sure that they're getting adequate time outside every day and that they're having a lot of play where they can nurture their creativity and, making sure that their environments, hopefully where they can do not necessarily, it would be great if it was deliberate meditation, but that our brain's creating theta waves, that we're kind of in the zone meditatively. We do all this stuff for little kids, and then we hit adulthood and we go, no, we're just going to power through all of it. I don't need fun. I don't need to move. I don't need to breathe deeply and do all these things I taught little kids to do. It's really simple. It's just very interesting how our culture has gotten so far away from these other aspects of what it means to be the owner of a human body.
Well, and, I do muse often over why it is that we don't do what's good for us. I go to 12-step meetings and I hear people saying, oh, it's my first meeting in 3 months. I know I should go. I feel better when I go. It works better when I go. And, I'm on the edge of relapse. And then I don't see him for another 3 months, or I know exercise is good for me. And, I'm in that human category, of course. So, we haven't talked about diet, but there's inflammatory foods, and the most inflammatory food is sugar. And for the longest time, I was consuming high amounts of sugar until one day I was lecturing and I hurt myself. And I said, the most inflammatory substance is sugar. And I said, geez, Mel, how about you do something about that? And I have pretty much eliminated sugar from my diet, and my inflammation, I got lots of aches and pains, but it's way better than it was when I was eating high doses of sugar. So the point is, it's hard to do protective things or beneficial things. It doesn't come naturally. It takes effort and diligence and energy and willingness. And frankly, it's a whole lot easier to take a pill or to hit social media or to watch TV than it is to go for a walk. So there is that sort of, overcoming resistance that's really part of the clinical work that all of your clinical practitioner listeners have to engage in. And of course, motivational interviewing is about working with the patient's ambivalence, meeting them where they are, and facilitating them move in the direction of health. And that is really that. This is a movement towards health.
Thank you for that, Mel. I think your mention of diet is an important part, and it goes back to looking at that biopsychosocial spiritual model of chronic pain. And I appreciate even your example about sugar. If we are going to make the leap that what's driving chronic pain usually starts with some kind of inflammation, of course, an anti-inflammatory diet makes sense. But it is also the kind of thing that if a clinician kind of takes this whole box of interventions and just shoves them down on the desk and says, okay, do all of these things, it's too much. And that's where we're going to, I think anybody is going to push back and say, no, I can't do all these things. You want me to change my diet and change my sleep. You want me to walk more. You want me to go do meditation. You want me to listen to this song. It's like all of these things I need to do. And I appreciate your recommendation of remembering this element too of motivational interviewing. And for our listeners, we have some great talks on motivational interviewing that are on the podcast. Please check those out. There's a series by Robert Scholes that I really recommend. But all of these things are linking together for me as a listener of what you're saying, Dr. Mel. For the folks who are listening and want to dive in and learn more about these concepts that you've mentioned today, what's the best way for them to do that?
Well, I'll mention a couple of resources. One is, of course, my book, The Pain Antidote. It really looks at the issues of pain and addiction and complex dependence. And there's a great section in that on diet. The more recent book that I highly recommend is called The Way Out by Alan Gordon and his Yoni Ashar, Ashar, and Alan Gordon. And Howard Schubiner is the physician, third author of that. That describes in great detail pain reprocessing and the methodology that I described earlier. Alan's works in the Pain Psychology Center, and they actually have a training that I took. I think it's a 4-week training. If somebody's really interested in this, it's probably the best out there. We use an app called Menda Health, MENDA, created by our psychologist, Les Aria. And it's a clinical app that provides group support and individual support and a bunch of resources for people with chronic pain. So if you have a patient or a family member or you're struggling with chronic pain and listening to this podcast, check out Menda, the Menda app. It's very, very effective. And the 5 points that I mentioned are on our website. The website is thepointmalibu.com, thepointmalibu.com. And then I have a website as well, drmelpohl.com, which is pretty outdated, but I'm working on it this weekend. So hopefully I'll have some new stuff in there.
Fantastic. Thank you so much for coming, Dr. Mel. You've shared so many pieces of information, and I know for one, I'm looking forward to pulling on some of those threads and learning more about these concepts that you introduced. Again, for our listeners, Dr. Mel Pohl joining us today. Please check out his website, visit Dr. Mel, and I'm going to make a guess here that were you to reach out to him, Dr. Mel would more than likely respond and give you some wonderful resources. At least that's always been my relationship with him. Thank you again for coming, Dr. Mel Pohl. Absolutely wonderful to have you, and thank you for sharing so much helpful information today. I appreciate it.
Thanks, Beth. My pleasure. Great to be with you.
You've just finished listening to another exclusive Continuing Ed podcast by Clearly Clinical. If you like what you just heard and you need Continuing Ed credits, please visit us at clearlyclinical.com to check out our 1-year membership, where you'll have access to our growing library of continuing ed podcast courses. Clearly Clinical, where our goal is to help you learn, grow, and shine.